All right, good morning, good afternoon, good evening, folks, wherever you're chiming in from. We're really grateful to have you here today. So today's webinar is on the health of Asian American and Native Hawaiian and Pacific Islander patients served at health centers, analysis of the 2019 Uniform Data System. Next slide, please, Albert. And some quick Zoom housekeeping. Before we get started, this webinar will be recorded and the slides will be shared to all registrants afterwards. So if you would like to unmute once you raise your hand to speak during the Q&A section, please feel free to click the left-hand button. And then the chat box is during the webinar. If you have anything you want to chime in about, feel free to do that. And with the blue pill, you can directly message specific people. So this is really great for technical issues. And then the Q&A box is specifically for questions that you have during the Q&A section. So we can directly respond to you or see that there's a whole list of them. So chat for general comments and the Q&A box for questions specifically. And then once the webinar ends, we will have a survey. And this helps us really improve our training and technical assistance materials. And it's really short, so we really appreciate if you could fill that out as well. Next slide, please, Albert. And then about AAPCHO. The Association of Asian Pacific Community Health Center Organizations, or AAPCHO, was formed to create a national voice to advocate for the unique and diverse health needs of Asian Americans, or AA for short, and Native Hawaiian Pacific Islander, NHPI for short, communities, and the community health providers that serve their needs. And if you go to the next slide, our mission and impact is really dedicated to promoting advocacy, collaboration, and leadership that improves the health status and access of Asian Americans and Native Hawaiians and Pacific Islanders within the United States, the US territories, and the freely associated states. And then from AAPCHO today, the presenters are me. So my name is Sakura Miyazaki. I'm the Program Manager of Training and Technical Assistance, Adam Carbolito, who is the Director of Policy, and Rosie Chang Weir, the Director of Research, and Albert Asen Jr., the Associate Director of Training and Technical Assistance. So if you have any technical issues, please feel free to directly chat Albert. And then next slide, please, Albert. Our amazing guest presenter today is representing the Pacific Islander Center of Primary Care Excellence, or PICOPSI for short. Manumalo Malo Ala Ilima identifies as Fa'atane, which means in the manner of a man in Samoan, and uses they, them, he, him pronouns. He is Samoan and of Tongan descent. They also have extensive community organizing and nonprofit leadership experience. Malo is a co-founder and first ever executive director of the United Territories of Pacific Islander Alliance Portland, or Utopia PDX for short. Utopia PDX provides sacred spaces to strengthen the minds and bodies of cutie pies, or queer and transgender Pacific Islanders, through community organizing, political engagement, and cultural stewardship. Utopia PDX is also the fiscal sponsor of OPIC, or Oregon Pacific Islander Coalition, which is a collective of 10 statewide Pacific Islander community-based organizations, 2 Pacific Islander employee resource groups, and some Pacific Islander community members not affiliated with the CBO or ERG. Malo is also the regional lead for Oregon on the National Pacific Islander COVID-19 Task Force and lead of their Data and Research Council. Malo was educated at the University of Southern California, majoring in political science with a minor in public policy and management, and comes to Utopia PDX executive director role in April of this year after having worked for over 15 years with the American Red Cross Biomedical Services in several functional areas and having lived in different regions. They have a small family with their amazing, lovely, and supportive partner, Elizabeth, and their brilliant, energetic 4-year-old, Eiley. So thank you so much, Malo, for joining us today. And with that, next slide, please, Albert. Before we get started, I'm sure you also noticed in the slides there are a lot of acronyms, so we just want to list that out explicitly here. So AA is Asian American, NHPI is Native Hawaiian Pacific Islander. And for the sake of readability, when we talk about Asian American and Native Hawaiian Pacific Islander serving health centers, we say AA NHPI serving health center. And then the same goes for Native Hawaiian Pacific Islander serving health center. So it'll be NHPI serving health center. And then last but not least, UDS stands for Uniform Data System. And with that, next slide, please, Albert. We want to turn it over to everybody in the room here. We just want to know which of the following best describes your organization type. And also in the chat box, if your organization has new or growing populations of Asian Americans and Native Hawaiian Pacific Islanders, please let us know your location in the chat and also the specific subgroup that your organization serves. So let's see. Give it about a minute and a half, maybe. Thank you so much, folks. See a lot of community health centers, but also a lot of government. Nice. Thank you. Thank you. Seattle, Washington, serving the elderly, Centers for Disease Control and Prevention. Yes, thank you for joining us in the chat. Thank you. Asian Pacific Partners for Empowerment, Advocacy, and Leadership, AAPCHO. Thank you, Marielle. Let's get about maybe 15 more seconds. Eastern Michigan University, Burmese, Chinese, Vietnamese, Nepali, Bangladeshi, Korean, and more. Excellent. Thank you. Thank you. Thank you, Albert. So we have 31% community health centers, 9% PCAs, 4% National Training and Technical Assistance Partner, 2% Health Center Control Network, 19% government, 7% academic, 15% social service or CBO, and 13% other. And definitely if you're other, again, feel free to chime in to see which organization you are in the chat. Thank you so much. Next slide, please, Albert. So based on this, our learning objectives today are 3 things. So 1, to present an overview of patient demographics, health utilization, and patient health outcomes at AA, NHPI, and NHPI serving health centers. And the second objective is to highlight key differences between AANHPI and NHPI serving health centers and other community health centers across the nation based on the 2019 Uniform Data System. And the last learning objective is to discuss the implications of key trends, findings, and opportunities to increase access to care and improve health outcomes at the AANHPI and NHPI serving health centers. So based on that, we have this agenda. So first is a spotlight on AANHPI and NHPI serving health centers with Rosie. Second is a voice from the field with Malo. And then third is summary and recommendations with Adam. And then last is tools and resources with Albert. And then the last 30 minutes is optional, but it'll be our Q&A section. So definitely feel free to use the Q&A box to keep chiming in. And with that, I will pass it over to Rosie for a spotlight on AANHPI and NHPI serving health centers.
And Rosie will just have to ask you to unmute yourself. Let's see.
It says she's muted, but maybe.
Okay, can you hear me okay?
Yep.
Perfect.
Okay, perfect. Sorry about that, folks. Thank you all so much for joining. My name again is Rosie Chang-Weir. I'm the Director of Research at AAPCHO, and it's such a pleasure to join today to talk about our national report. So in this report, AAPCHO analyzed the National Uniform Data Set from the 2019 data to observe the growth and diversity of Asian American and NHPI populations served by AANHPI serving and NHPI serving health centers. So Asian Americans and Native Hawaiian Pacific Islanders are the fastest growing racial or ethnic group with over 23 million residents living in the continental US, Hawaii, US territories, and COFA nations. AANHPIs represent more than 50 racial and ethnic groups and over 100 languages spoken. And from 2010 to 2019, the Asian population in the US grew about 81% from roughly 10.5 million to 18.9 million people, whereas the NHPI population grew 61% from roughly 370,000 to 596,000 people. And just for comparison, Hispanics saw the second fastest population growth between 2000 and 2019, followed by NHPIs. In terms of growth rates, North Dakota and South Dakota saw the fastest increases in their Asian American populations between 2000 and 2019. Chinese Americans, Indian Americans, and Filipino Americans account for the largest Asian origin groups in the US, and nearly half of US Asians live in the West, with nearly a third here in California alone. So let's go to the next slide. Let's see, just move this off my screen. Okay, So our data source for our analysis is the uniform data set. So each year, health center grantees and lookalikes report on their performance using the measures defined in this uniform data system known as the UDS. So the UDS is a national standardized reporting system that provides standardized health center data, including health center patient population characteristics, enabling services, workforce staffing, and quality of care measures. So in 2019, a total of 1,385 health centers in the continental US, Hawaii, US territories, and COFA nations reported to the UDS. Of note, though, is that some health measures that are significant to our populations may not be referenced in the UDS and found in other data sources. So for the purposes of this report, AAPCHO formulated a specific methodology to create a profile of the Asian American and Native Hawaiian Pacific Islanders serving health centers, as well as for the Native Hawaiian Pacific Islanders serving health centers. So we define AAPCHO serving health centers as health centers that serve the highest number of Asian American, Native Hawaiian, Pacific Islander patients, as reported again in the 2019 UDS data set. So we use the top 10% of the 1,385 health centers that reported in the UDS. And then we define NHPI serving health centers as health centers that served greater or equal to 1,000 Native Hawaiian Pacific Islander patients as reported in the 2019 UDS data set. And so based on these definitions, we at AAPCHO identified and analyzed a total of 139 AA and NHPI serving health centers and 44 NHPI serving health centers from the 2019 UDS data set. All but one of the identified NHPI serving health centers are included in the 139 identified AA and NHPI serving health centers. The averages that we'll be reporting in this analysis were calculated using this raw UDS data, and in our analysis, in order to determine the statistical significance between groups, we used two sample t-tests that were conducted using a significance level of 0.05. So let's move on to the next slide. We wanted to take a moment to recognize the limitations of our data set and analysis up front to be able to provide context for our analysis, because we often get a lot of questions about this. So first, the UDS data set provides only summary health center profiles, including population characteristics, but it does not contain patient-level data. So unfortunately, we could not do direct comparisons or direct cross-tabulations between AN and NHPI populations and other racial ethnic groups for the majority of the UDS data. Thus, we had to use health center averages based on the largest proportions of the AN and NHPI populations as a basis for our comparisons. We're very well aware that UDS aggregate level data masks potential health and demographic differences and hides disparities between subgroups found in our other studies. So for example, a lot of other studies demonstrate subgroup differences, such as Filipinos, Hmong, and South Asians having higher rates of diabetes compared to other Asian American subgroups and white persons. By aggregating Asian Americans, we all know that health disparities within racial groups are hidden. In addition, our current definitions of our ANHPI and NHPI population groupings may unintentionally exclude smaller health centers that serve a larger proportion of these patients from the analysis. So for example, since the total number of patients are lower at smaller health centers, these health centers would not be included based on our definitions that selected health center groupings of our selected health center groupings based on their serving 1,000, the requirement that they serve 1,000 NHPI patients. So even with all these limitations, the UDS serves as the only data source for national standardized information collected by health centers. So it is still a rich data source. So AAPCHO had to formulate this methodology to highlight groups of Asian American, Native Hawaiian, Pacific Islander populations. And we continue to utilize this specific methodology to create this profile of ANHPI serving health centers and NHPI serving health centers to better understand the health status of the population served within our communities. With improvements, in the UDS data structure and better understanding of the ANHPI serving and NHPI serving health centers and the populations they serve, we're committed to refining these definitions to more equitably represent A's and NHPIs in future iterations of this report. So let's move to the next slide. So in the 2019 data set, a total of 1,385 health centers in the continental US, Hawaii, and US territories and COFA nations reported their data to the UDS. Based on AAPCHO's definition, there were 139 AA and NHPI serving health centers and 44 NHPI serving health centers. And this table provides a breakdown of the total number of these health centers within their locations. So in 2019, 1385 health centers served a total of roughly 30,000 patients, and roughly 1.35 million, or 5.3% of the total, were AA and NHPI patients, and roughly 283,000, or 1.1% of the total, were NHPI patients in the health center program. Let's move on to the next slide. Besides the continental U.S., the NHPI serving health centers are also geographically diverse and dispersed throughout the Hawaiian Pacific. So the Pacific region includes the two U.S. territories of American Samoa and Guam, the Commonwealth of the Northern Mariana Islands, and the three freely associated states of Palau, Marshall Islands, and the Federated States of Micronesia. Move on to the next slide. Overall here, I wanted to highlight the proportion of the AA and NHPI patients in our targeted analysis groups versus the total population in our in the UDS data set. So in the overall health center program, 1385 health centers serve a total of almost 30 million patients, as mentioned, and 5.3% are AA and NHPI patients, 1.1% of the total are NHPI patients in the health center program. Whereas in our target analysis groups, we had the 139 AA and NHPI serving health centers that served a total of almost 8.3 million patients, among which 14.5% were AA and NHPI patients. And so in total, the AA and NHPI serving health centers served 71% of all AA and NHPI patients. And then the 44 NHPI serving health centers served a total of roughly 3.2 million, among which 7.1% were NHPI patients. And so the NHPI serving health centers in our targeted analysis group served 64% of all NHPI patients. So in summary, the point here is that you can see that our targeted analysis groups represent a majority of the AA and NHPI patients compared to the total population nationally in the health center program. Okay, so let's go to the next slide, and let's just get right into the analysis results. So in general, health centers nationally serve a high proportion of patients with one or more social risk factors. And so here is a graph that compares the national with the AA, NHPI, and NHPI serving health centers. So within this graph, the yellow color represents the national health center average, blue is the AA and NHPI serving health centers, and green is the NHPI serving health centers. So compared to health centers nationally, both the AA and NHPI serving and NHPI serving health centers report a higher proportion of patients with limited English proficiency, incomes below 200% of the federal poverty level, Medicaid, and public insurance. AA and NHPI serving and NHPI serving health centers both reported a lower rate of uninsured patients, and this could be attributed to the Medicaid expansion and insurance marketplace enrollment efforts under the Affordable Care Act. The lower rate of uninsured patients may also be attributed with the higher rates of supportive enabling services staff employed at AA and NHPI serving and NHPI serving health centers. Health centers generally provide these enabling services to reduce patient access barriers to care. So they include interpretation for limited English proficient patients and transportation in order to access appropriate care. Many of these health centers also employ, for example, eligibility assistance workers as enabling services staff whose specific role is to enroll uninsured patients into public insurance programs. So it's important to note that the UDS provides data on health insurance status for both the U.S. territories and COFA nations. However, it does not provide a reflection on the various health coverage eligibility factors for COFA nations based on immigration status and their relationship to the U.S. Let's move on to the next slide. In terms of chronic disease, according to the 2019 UDS data set, 11% of adults were diagnosed with diabetes and 19% of adults had hypertension at health centers nationally. So this table shows the average health center patients with uncontrolled diabetes and hypertension by race and ethnicity. According to the analysis, 37% of Native Hawaiian patients, denoted by the lighter red color, and 30% of Pacific Islander patients, denoted by the darker red color, have uncontrolled diabetes, whereas 39% of Native Hawaiian patients and 37% of Pacific Islander patients have uncontrolled hypertension. Comparing across all races and ethnicities, Pacific Islander patients have the highest rates of uncontrolled diabetes, and Native Hawaiian patients have the second highest rates, paralleled with American Indian and Alaskan Native patients. For uncontrolled hypertension, Native Hawaiian patients have the second highest rates, and Pacific Islander patients have the fourth highest rates. And compared to the other racial ethnic groups, Black and African American patients have the highest rates, and American Indian and Alaskan Native patients have the third highest rates. The high rates of chronic diseases in the Native Hawaiian Pacific Islander patients could be attributed to the social economic disparities, structural discrimination, and pre-existing conditions. This provides an opportunity for health centers to develop chronic disease management programs that are culturally responsive to each racial and ethnic group. So for example, the Pacific Islander Diabetes Prevention Program serves as a model to build the infrastructure of local organizations to deliver Pacific Islander tailored and CDC recognized lifestyle change programs to Pacific Islander communities. The lower rate of uncontrolled diabetes among Asian American patients compared to white patients may be attributed to potentially high rates of misdiagnoses, since Asian Americans are at risk for type 2 diabetes at a lower body mass index than the standard screening guidelines. Additionally, the lower uncontrolled diabetes rates could be attributed to the aggregation of the Asian American patients as one racial ethnic group, as we noted earlier in the limitations of the data. So as I mentioned earlier, several studies looking at subgroups such as Filipinos, Hmongs, and South Asians show them to have higher rates of diabetes compared to other Asian American subgroups and white persons. Again, by aggregating Asian Americans, the health disparities within this racial group are masked and hidden. Let's move on to the next slide. Regarding hepatitis B, Asian Americans make up 6% of the total population in the United States, but account for 58% of the 862,000 people living with chronic hepatitis B. And this figure here displays the average rates of hepatitis B per 100,000 persons from the ADS data set. According to this analysis, AA and NHPI serving health centers represented in blue, and NHPI serving health centers represented in green serve a higher rate of hepatitis B patients than the national average, represented in yellow. Let's move on to the next slide. AA and HPI serving and NHPI serving health centers demonstrate higher rates of certain quality of care measures as well, including childhood immunization, cervical cancer screening, and controlled hypertension than health centers nationally. We believe these results may be attributed to the higher rates of enabling services staff, which are associated with higher quality health outcomes. As you can see here in the table on the right, compared to health centers nationally, AA and HPI serving and NHPI serving health centers have more full-time equivalent enabling services staff. So for example, AA and HPI serving and NHPI serving health centers have 3 and 1.7 times more interpretation staff, respectively, compared to the health centers nationally. In terms of colorectal cancer screening, AA and HPI serving health centers demonstrate slightly higher rates of colorectal cancer screening than the national average. However, challenges do remain for all Asian American populations to get screened and tested due to language barriers, inadequate communication with providers, and stigma. Although enabling services support in improving health outcomes, health center quality outcomes in 2019 did not meet the Healthy People 2020 goals except for controlled hypertension rates. And then as Healthy People 2030 is unveiled, there will be opportunities to establish new benchmarks and innovate care to improve health outcomes for AA and HPI patients to be able to address other contributing factors to health disparities. So overall, this quantitative data is really important, but it's always helpful to obtain qualitative voices from the field from our fellow community members as well. So we're very, very fortunate to have Malo join us in this opportunity. So I will go ahead and turn it to them. So thank you again for your interest and attention to learning more about our communities. Thank you so much.
Thanks so much, Rosie. And yeah, we'll pass it over to Malo now for a voice from the field.
Talofalava, malolele, fapataitililava moleava noa. Warm Pacific greetings in Samoan and Tongan. Thank you for the opportunity to the AAPCHO team to be able to share about my experience with respect to the evaluation process with the UDS report. But before that, I will be giving more context so that those of you in attendance can understand the journey of what the Pacific Islander communal embedding process is like when it comes to data and research. So next slide, please. Thank you. Community-led data and research engagement. NHPI serving health centers and other agencies initiate an intentional partnership with culturally specific NHPI and community-based organizations, or CBOs. So whenever your particular FQHC is located and there is an NHPI demographic that you can serve, when it comes to encouraging intake or feedback from this particular community, it would most culturally, it is actually most appropriate to invite trusted NHPI CBOs to help consult on best cultural practices on the type of messaging and delivery systems to your patients or clients. And during the pandemic, local NHPI CBOs have deepened trusting relationships with their NHPI patients, clients, and communities. Nothing more resounding and eye-opening than during the pandemic, whereby the local NHPI's CBOs have deepened these trusting relationships, but also with local public health authorities and many of you, our community health centers and partners. This absolutely leverages the kind of response one would hope to receive by using the community's most trusted messengers, your culturally specific CBOs. These are our folks who provide sufficient in-language, educational, and informational tools. These are our folks who can interpret and help ease understanding of the healthcare process to our clients. Truly having community helpers and supporters ready to spring into action to help get information out and also receive information from community makes so much sense to utilize our culturally specific CBOs. NHPI CBOs convened at the national level for COVID-19 response. That organizing at the local and regional level by our NHPI CBOs truly elevated to the national level due to the pandemic, garnishing participation from Arkansas, Arizona, California, Utah, Oregon, and Washington, as well as in Hawaii, sharing these best practices to advocate for disaggregation of data among AA and NHPI with respect to COVID-19 rates of infections, hospitalizations, and deaths, on how to advocate for adequate resources to help provide wraparound services for our infected and those exposed to that. We formed the National Pacific Islander COVID-19 Response Task Force, or PICRT, under the Pacific Islander Center of Excellence Primary Care, or PICOPC. This truly helped us to identify gaps and deficits, but also some amazing insights and strengths we had as a community. The PICRT is transitioning into a newer iteration called NAOPO, the National Association of Pacifica Organizations for the US continent, and to be inclusive of Hawaii and the US affiliated Pacific Islands. So we formed the National Pacific Islander Data and Research Council under the PICRT that is under PICOPC. And we have 3 other councils for a total of 4 councils. We also have the Policy Council, the Resources and Engagement Council, and finally, the Media and Communications Council. And the Data and Research Council, we are comprised of mostly Pacific Islander community members and some Pacific Islander researchers from different regions throughout the US continent and Hawaii. With this type of compilation, we are able to contribute with more consideration as well as with expediency through our network to disseminate and receive information. We have centralized our NHPI regional areas into one council for the very purpose of NHPI research data and, related to data and research. Culturally specific responsive community feedback, which should be the next slide. Yep. Essential to equity in data and research collection, analysis, and evaluation. So this was quite apparent in AAPCHO's inclusivity and reaching out approach to the National Pacific Islander Data and Research Council to help provide insight and perspective to this UDS report. AAPCHO has been quite receptive of our review and recommendations, which is a remarkably pleasant experience. There were a couple of recommendations that weren't able to impact this report, but will be considered in preparation for the future. Affirms the data and research that is for a particular community should be in thoughtful partnership with that said community. Our NHPI community felt seen and heard by participating on the review for the UDS report. This type of clear community engagement accentuates our visibility and active participation in what is being collected, analyzed, and evaluated for our community. AAPCHO has provided us with the platform and visibility needed to be inclusive of our NHPI community's voice with respect to this data and research. Critical to NHPI framing and nuance to health outcomes. This is probably the most crucial piece on how to interpret the results. Having the ability to develop the framing and nuance to explain health outcomes from a cultural lens is empowering. It allows for us to shape what we want for others to know about how we see our health and the quality of care playing out in the US healthcare system. It informs development of relevant health policy, resource attainment, and risk mitigation and resolution. Our ability to be involved in the data and research process in any particular project also aids in informing how to develop or support how our health policy could be like for our community, the types of resources that are allocated to our community, and to also help us mitigate and manage risk, as well as be involved in the resolutions of these health outcomes. Whakataite lava mula avanoa, AAPCHO, thank you for the opportunity to share AAPCHO, for your partnership, and we look forward to collaborating on more meaningful projects soon.
Thank you so much, Malo, for providing your amazing perspective and also recognizing us too. We really could not have polished this report to such an excellent degree without the NHPI feedback. So we also want to push back and say thank you so much. And we are so grateful for you also presenting for this webinar as well. And also, if folks have any questions, again, reminder to put anything in the Q&A box. Thank you everyone for your participation so far. And I will also now pass it over to Adam for the summary and recommendations.
Thank you, Sakura. We can go to the next slide. And I also want to thank you, Malo, and the Data and Research Council and AAPCHO for your partnership. As Sakura mentioned, we could not have done this report without your partnership and collaboration. And really, this is the most robust UDS report that I think AAPCHO has ever provided, and we couldn't, it wouldn't have been this robust and this informative if it wasn't for your partnership. So thank you again. The 2019 UDS dataset really reveals similarities and differences between AA and NHPI serving health centers NHPI serving health centers, and health centers nationally in the United States, the US affiliated Pacific Islands. And we have a few key observances. First is overall AA, NHPI serving, and NHPI serving health centers serve higher proportions of patients with limited English proficiency, who are low income, on Medicaid, or have public insurance compared to health centers nationally. AA and NHPI patients demonstrate chronic disease disparities such as diabetes and hypertension compared to other racial and ethnic groups. AA and NHPI serving health centers demonstrate higher rates of hepatitis B compared to health centers nationally. And AA and NHPI serving health centers demonstrate higher quality of care in areas of childhood immunizations, cervical cancer screenings, and controlled hypertension. Higher quality of care results are in part attributable to the health center's higher full-time equivalent rates of enabling services staff, which I'll talk about in some of the recommendations. Next slide, please. As I mentioned, AAPCHO does recommend specific next steps following this UDS report. First of which is increased collection of social risk data and disaggregate race and ethnicity data. In screening for and collecting data on social risk factors, as we see in the 2019 UDS findings, these findings indicate that 71% of health centers collect data on social risk factors. Without this critical data, AA and NHPI patients, their unique health and social needs that impact their ability to access healthcare and improve health outcomes will continue to be hidden or overlooked. And this is something that we have also seen throughout the COVID-19 pandemic. When we do not have appropriate, robust data on our communities, the interventions that are needed cannot be specifically targeted to address the specific concerns of specific communities. So AAPCHO recommends that 100% of health centers move towards the adoption of social risk factor screening and implementation of appropriate social interventions. Secondly, there is a critical need for better, more robust, and consistent disaggregation of race and ethnicity data. As Rosie mentioned, Asian Americans and Native Hawaiians and Pacific Islanders are extraordinarily diverse communities. We represent over 50 racial or ethnic groups, and our communities speak more than 100 languages. Each subgroup is diverse in our culture, our health beliefs, our language, and our socioeconomic background. But unfortunately, oftentimes, data in our community is not readily available. And in instances where Asian American and Native Hawaiian Pacific Islander data is reported, it is often aggregated in a way that masks the challenges and negative outcomes to our specific communities and our specific population groups. It is recommended that health centers receive expanded training and technical assistance on the collection of detailed race and ethnic data to identify unique health characteristics that exist within broader racial and ethnic categorization subgroups, such as the Pacific Islander subgroups like the Marshallese experience with diabetes, or within Asian subgroups like Filipinos experience with hypertension. Health centers can leverage this disaggregated data to cultivate new or expand existing programs and services that are culturally and linguistically appropriate for our communities. And beyond data collection among health centers, it is recommended that all national, regional, state, and local data sets disaggregate by race, ethnicity, and preferred spoken language. As I mentioned, the need for consistent, robust, and disaggregated data at all levels of government is absolutely imperative, and the COVID-19 pandemic really has showcased that without appropriate data disaggregation, the experiences of our communities, the specific experiences of specific subgroups within our communities can be hidden and masked, and it prevents healthcare providers and government institutions and private institutions from really focusing and targeting interventions that are appropriate, that are culturally and linguistically appropriate to those specific communities. Next slide, please. Our second recommendation is to tailor health and social services that reflect the needs of Asian American and Native Hawaiian Pacific Islander patients. Asian American and Native Hawaiian and Pacific Islander patients have a diverse array of health, mental health, and social needs, and it is necessary for culturally and linguistically appropriate services by healthcare providers to be provided by healthcare providers. Investing in programs and care delivery models tailored for specific Asian American and or Native Hawaiian Pacific Islander communities can help improve patient-centered care and address disproportionate rates of diseases, such as the high prevalence of diabetes, hepatitis B, and tuberculosis among our communities. AAPCHO recognizes the importance of tailoring patient-centered interventions, and we have worked to create culturally responsive programs and care delivery models that address specific chronic and infectious diseases that disproportionately impact Asian Americans and Native Hawaiian and Pacific Islander patients. Three of the initiatives that AAPCHO has been instrumental in creating to address these health disparities and the models that we have built to target specific interventions to our communities include the Hep B United Coalition, the Pacific Islander Diabetes Prevention Program, and the Tuberculosis Community Engagement Network, all three of which are highlighted here, and you can click on the links to learn more about each of these initiatives. Secondly, we encourage better hiring, training, and sustainment of Asian American and Native Hawaiian and Pacific Islander non-clinical healthcare workforce. Asian American and Native Hawaiian and Pacific Islander serving health centers have historically invested in non-clinical staffing, known as enabling services, to ensure availability of in-language, culturally relevant support and critical navigation services that have been shown to increase health centers' visits and patient satisfaction. Critical services include eligibility assistance, to ensure patients keep and retain their health coverage are necessary to supporting continuity of care. It is known that health insurance coverage increases access to preventive care services to prevent and or manage chronic and infectious diseases, including, as I mentioned, diabetes, hypertension, hepatitis B among Asian American and Native Hawaiian and Pacific Islander patients. Health insurance coverage and retention are multifaceted processes impacted by high policy level down at the provider level. And I also want to highlight that language barriers pose an important and significant challenge for our community members. We are fortunate that AA and HPI and NHPI serving health centers are able to provide care and help patients navigate the healthcare system in the language their patients can understand. But adequate language access services are not always available. And COVID-19 has really shed light on how dangerous and widespread this challenge is. It is imperative and it is recommended that individuals are communicated with in a language they can understand, and that there needs to be more availability of qualified interpreters, multilingual staff, and translated materials at every stage of the patient experience. These enabling services staff play a critical role for patients to navigate the complex insurance system and must be factored into value-based payment efforts to ensure long-term sustainability. It is also recommended for health centers to offer workforce skills-based training on principles and concepts of cultural humility to help staff and providers navigate multicultural communities more effectively. It is recommended for health centers to re-examine and reorient health centers to nationally recognized frameworks, such as the National Standards for Culturally and Linguistically Appropriate Services, or CLAS standards, and in health and healthcare, in which have served as foundational guidelines to increase health equity and increase health disparities. Next slide, please. Finally, we really want to cultivate and sustain community and national partnerships. The first aspect of this is to promote cross-sector community partnerships. Health centers may not be able to provide comprehensive in-house services that address all of the social needs among vulnerable Asian American and Native Hawaiian and Pacific Islander populations. And community partnerships are critical to address the whole of person needs of patients. And as I mentioned, I really want to thank PICOPSI for the partnership that they had with AAPCHO in developing this UDS report and in other initiatives that we are putting forward to address the needs of this of the NHPI population. It is PICOPSI is an example of the strong community partnership that we've had, and it is a model that I think would work to improve patient outcomes and promote this stronger cross-sector community partnerships. It is recommended for health centers to cultivate existing and or explore new community partnerships with local service agencies, faith-based organizations, and or community-based organizations to address social needs that are unique to Asian American and Native Hawaiian and Pacific Islander populations to be better equipped with resources aimed to improve the outcomes of our communities and our patients. The second aspect of this is to leverage state and national networks, resources, and expertise. HRSA funds a diverse array of state and national organizations that directly support health center programs, and it's recommended for health centers to access and partner with their state and or regional primary care associations, the health center control networks, the National Health Center Training and Technical Assistance Partners that focus on addressing AA and NHPI health disparities. Through these partnerships, health centers can strengthen existing policies that may result in increased funding and resources to address health disparities for Asian American and Native Hawaiian and Pacific Islander patients living throughout the United States and the US affiliated Pacific Island jurisdictions. And with that, I will turn it over to Albert for some tools and resources.
Thank you so much, Adam, for the recap on the summary and recommendations following, again, our great presenters from Rosie and Malo. So just to kind of take away some key resources, and I know Joe and our AAPCHO colleagues are putting links in the chat box. Those are for you all to take and read on your own time, but I want to highlight 4 key resources for this presentation today. So for the publication, we are in the review process with our funder, the Health Resources and Services Administration, which is the Bureau of Primary Healthcare. This screenshot here is the report from last year, which is based on the 2018 Uniform Data Systems. So we hope that the report for the 2019 UDS, which we highlighted today in summary form, will be available later this summer. So as participants for today's webinar, you all will get a follow-up email once that publication is approved. And again, we want to thank all of our community reviewers and feedback from the stakeholders across the country, including our NHPI Serving Health Center and NHPI Serving Health Centers. It has really been a impactful and intentional process compared to previous years. So that's coming pretty soon. As Rosie highlighted in the beginning portion, again, a lot of the information presented today is based on the Uniform Data System, which is an annual reporting requirement for all federally qualified health centers. And so this report is usually due mid-February, and you'll see on this screenshot here, all health centers, again, are required to submit February 15th, 2021. And just to kind of align it with some of the talking points around social risk factors and collecting really discrete data on social needs, there are new questions in this new manual for 2020 related to health centers' data collection processes related to social risk factors, because we want to acknowledge that it's not just what happens in a healthcare setting that really impacts health outcomes, but what's happening outside of the health center or clinical delivery systems in terms of the community, the neighborhoods, and the built environment that our patients and populations are living in. And so the Bureau of Primary Healthcare and HRSA are really digging deeper into what's happening within the health center program and outside the health center program, which again do impact some of those clinical quality measures. And so one of those questions I just highlighted here is, does your health center collect data on individual patients' social risk factors? Because we want to acknowledge that Rosie mentioned the health center program requirements is really at an organizational level, not necessarily at a patient level. So there are key questions that are going to be asked of you all, especially if you're health centers. In terms of another tool, and sorry for the typo here, but we also have prepared the PREPARE, which is the protocol for responding to the assets and patients' assets, risk, and experiences. In short, it's PREPARE. This is the #1 social risk screening tool used by health centers, around 34% of all health centers across the country. And Joe had hyperlinked for you all that toolkit, which is about 10 chapters. And this assessment itself has been translated into 26 different languages, including some Asian Pacific Islander languages, which again, you can find on the website that is provided in the chat box. Again, the translations for this were community vetted. And so we want to thank all the health center partners who were involved in this translation process, since we couldn't do it without the feedback and the buy-in from the community. And then the last toolkit that we want to share with you all, if you haven't already accessed it, it's the Enabling Services Data Collection Toolkit. As Rosie and Adam had shared, again, really acknowledging the role of enabling services, which for health centers is the non-clinical services that facilitate access to care. So those services include health education, outreach, case management, referrals, etc. Those are really impactful in terms of addressing patients, not just clinical needs, but non-clinical needs, and that includes the social determinants of health. And so in this toolkit, which we partnered with some stakeholders from the community, state, and regional perspectives, we have developed a way to have you all self-implement, and this requires you to fill out this needs assessment. There's a readiness assessment, some workflow exercises, and then if you have some of your EHRs like GE Centricity, ECW, NextGen, there are some EHR directions for you all to kind of bring back to your own health centers or organizations. And again, additionally, we have other strategies around a database collection strategy, some training guidelines for your staff who are going to be collecting data, and then some report cards you can develop in-house. So again, all meant to be very much self-implemented if you read the guide from front to back. And that's available again on the enablingservices.apcho.org website. So in summary, please do let us know if you have questions about any of these resources. The AAPCHO training and technical assistance team is available to you all for any coaching or any additional support you may need offline. So with that, I'm gonna pass it back to Sakura for our Q&A portion.
Thank you so much, Albert. And yes, these slides will be available after the webinar. And also I saw Joe also putting in the links for all these things. So please definitely check it out. And again, as Albert said, please definitely reach out to us. Our email is training@apcho.org if you need any support. And with that, we would love to open the Q&A section. Please feel free to put any questions in the chat. We have 6 minutes left until it's top of the hour, but we'll have another 30 minutes just in case we need more time. Would like to start for a question to Malo. So I know that you had discussed culturally responsive strategies and community-led processes to really strengthen relationships and linkages for NHPI community organizations and leaders. But I was also wondering, what can community health centers specifically do to continue to engage this community and kind of give a more expansive overview of what you just said?
Thank you for the question. I think just being aware of other options that your NHPI patients might need within the community. So just maybe a search online to see who are your Native Hawaiian and Pacific Islanders serving culturally specific CBOs or cultural community-based organizations in your area. Because that's like added resources for your patients. And I know for our local public health authority, I live in Multnomah County, so it's Multnomah County Health Department. And working directly with the health department, they have a list of different providers, you know, that could potentially have Native Hawaiian and Pacific Islander patients. And so they would list, you know, as a service, you know, for all of the providers in the jurisdiction for that LPHA, all the culturally specific CBOs for the Latinx community, the Native Hawaiian and Pacific Islander community, the Asian community, the Native American and Alaskan Native community. So I think they just learned that in order for there to be true impact in shifting certain ways of how we look at health and wellness within certain communities, it was, they took on that onus to provide the providers, with these very culturally specific CBOs that are already doing direct service. And so it complements the type of healthcare we can envision or reimagine for our community members. But I would look online, but then I would also just reach out to the local public health authority where you're at. Thanks for the question.
Thank you so much, Malo. That's an excellent point, to reach out locally, and the internet's always a great resource too. So thank you so much. And I think with that, there's kind of a similar question, and you definitely already touched on it, but how can health center data like the analysis in this report be used to inform and support NHPI organizations and communities? And maybe what other information would be helpful?
Thank you for the question. I'm really fortunate to live in Oregon, where Real D is collected, and so is SOGI. So that's race, ethnicity, and language and disability, as well as SOGI, which is sexual orientation and gender identity. So I think we're fortunate in that regard that we can ask for these things as people do intake or as they do surveys, that they would include these pieces because it's helpful for everybody to know what's going on in their community. So when it came to advocating for, in particular, COVID-19 data, yeah, it really helped us to hone down on areas that we needed to focus on. So I'll just use a more recent example for vaccination rates. We could tell in which counties that we need to focus on because it's lower than other counties. And so we can shift our resources to ensure that we do more messaging and the kind of messaging. So like, is it, from 12-year-olds to 17-year-olds that have a low vaccination rate? And again, I think it started with having a good relationship with our LPHA, and then our version of the Department of Health is the Oregon Health Authority, and just having access to folks there who are willing to crunch numbers for us and not put up barriers or obstacles when it comes to how data is being shared or even talked about certain communities.
Thank you, Malo, and thank you again for highlighting the importance of relationship building and also providing a specific example to how NHPI communities and leaders had a rapid response based on data. We also have another question. Let me see. Collecting disaggregated data is a great first step towards more refined clarity on our AA and NHPI patients. What are the next steps for the UDS to present this disaggregated data? Do we as PCAs, CHCs, and partners have a say in this? Rosie or Adam, would you like to chime in?
Sure. Hi, this is Rosie. We've been advocating with HRSA and with everyone, as Adam had mentioned in the recommendations, that it's really important to be able to collect this data, this disaggregated data, given the diversity in our populations, that's really really masks all of our differences within the subgroups of the larger categorization. And so I think maybe Albert or Joe could talk to some of the efforts in working with the Bureau and HRSA to collect this, to advocate for this subgrouping data collection. And also, I think as PCAs, HCCNs and health centers, I think you could all, especially, if you have those larger groups within your health centers, it would be great to be able to better understand by collecting this disaggregated data within your own communities, and to share that information and share the the differences within the subgroups, and to collectively advocate with us in terms of with HRSA and the Bureau to make sure that they are collecting this disaggregated data, so that we can make sure that that disparities are no longer hidden for our populations, and we can obtain the resources needed to be able to address the health of these communities.
Thank you,
And I'll just add, that's exactly right. I think that, yes, absolutely, the PCAs, the health centers, and partners absolutely have a say in this. Making it known to HRSA and to your local and state public health departments why it is important that data is collected and disaggregated by our communities, and giving those real world examples on the importance of disaggregated data, similar to what Malo was sharing. On how Oregon does collect and report disaggregated data, the real D data, as well as the SOGI data. And that wouldn't have been possible if it were not for community organizations, for interested stakeholders, and community members petitioning the government and the policymakers in charge of this data to make it a requirement within the state, and at the federal level to require or to petition and encourage HRSA to also have health centers collect and report this data, and then have Congress and the administration more broadly provide standards so that it is, as I mentioned during the recommendations phase, that it's not only collected one-off, but that there is a standardized, consistent, uniform method of collecting and reporting disaggregated data across government and across programs, I think is imperative. So, having those real-world examples on the importance of this data collection and how it is that using this type of data will help inform specific targeted interventions to community groups and populations is absolutely imperative, and it helps to build the narrative and build the justification for on why this is needed.
Thank you. And I think there's another question that kind of is on the same level, where this is for Rosie and Adam, and also Malo, if you would like to chime in. What do you anticipate the 2020 UDS data to look like? Any similarities or differences from the 2019 data? Maybe you could, Rosie, you could start with the data perspective.
I think we're having audio issues with Rosie. Rosie, are you able to unmute yourself?
Sorry about that. Yeah, I was just going to say, I think there are some minor changes, but that I'm aware of. But I don't know if Albert, you can mention some of the other changes. I think there's, I think there's always talk of wanting to, modernize the UDS and all of that. I think there's there hasn't been a lot of movement around that I'm aware of, but I know they're exploring changes in how the UDS is going to be collected. But I think for the 2020, I'm not aware of any major changes that are going to be happening, like the subgrouping, of course.
Yeah, in terms of just the ones I mentioned briefly in the tools and resources section, there are optional health information technology questions related to again, what you're doing around the social determinants of health and other related EHR, EMR related question. And so those are going to be a part of like the appendix. In addition to modernizing kind of the enabling services, that's something that we're trying to work with the Bureau of Primary Healthcare on a national, federal level, as Adam mentioned. And so we're trying to have talks with the Data and Evaluation Department, and also MITRE, which is on board with modernizing the UDS with community feedback. So if there is, again, some talking points that you'd like us to share on behalf of you all working on the ground with the health centers and your patients, please, again, email us at training@apcho.org. We'd love to have those incorporated into any reports when we meet with the feds in the fall. In addition to, again, I think there's a question here around, are you all having issues with collecting SOGI data? So that's the sexual orientation, gender identity data. Again, that can be very technical. We know that a lot of the major EHRs already have pre-populated and structured data fields where patients, again, can indicate their sexual orientation, gender identity. But again, that's usually taken during the intake, front desk, receptionist process. And so I know some of the challenges, of course, are getting patients to fill that field out. So there's a lot of soft skills training, and I want to give a shout out to the Fenway Institute or the National LGBTQIA+ Health Education Center, which Joe put in the chat box. They do a lot of culturally affirming training on how to collect SOGI data with patients to make sure that it's culturally sensitive to the needs of the different populations. And so please do check out their website for some of their videos and publications. And if you need a warm handoff, we're happy to do that for you as well.
Thank you so much, Albert. Any other questions? And definitely doesn't have to be a question too. We are learning just as much as everyone else here in the room is as well. So if you'd like to unmute and share any best practices or thoughts about recommendations, definitely please let us know. Also in the chat box too. So let me see if there's any other questions. Don't see anything else. Thank you, Nathaniel, for including the UDS link. Yes, Joe's SOGI. Yes, there's a lot of links in here. And we can definitely include that in the slides retrospectively as well. But if there's no other questions, I think we might be good to go. Okay. All right. Okay, folks, I think this is good. Thank you, Malo, for joining us and the fabulous AAPCHO presenters as well. I know we put a lot of work into this, so super grateful. And thank you everyone for joining us today. And again, the Bureau is still reviewing a report, but as soon as everything is finalized, it'll be live on our website. And we'll follow up with everyone for the slides and recording as well. So thank you so much and take care.